know we have a couple. Perfect, thank you. I know we have a couple more panelists joining us, so we'll do our quick introduction and then pass things over and hopefully they're able to connect. Hey, good morning, everyone. My name is Christy Allen. I'm the Knowledge Translation and Implementation Coordinator with the Waypoint Research Institute. Welcome to today's Waypoint Talks session. Today we are talking about building a network in IPV research and the importance of community partnerships in amplifying and enhancing research. So we'll start with a land acknowledgement. The Waypoint Research Institute is located on the traditional territory of the Anishinaabe, which include the Odawa, Ojibwe, and Potawatomi nations, the Haudenosaunee, Huron, Wendat, and Métis peoples. We acknowledge and affirm our commitment to improving relationships between nations and to improving equity for Indigenous communities residing in the Central North region of Ontario. And if you know where you're joining us from today, we invite you to share that in the chat as well. So welcome to Waypoint Talks. Waypoint Talks is a virtual webinar series offered by the Waypoint Research Institute aiming to highlight practical implications of research projects. We also have a complementary series, Waypoint Talks Building Your Research Toolkit, and this series focuses on best practices used in mental health research, quality improvement, and program implementation. And these events are open to all who are interested in learning about emerging research, best practices, clinical innovation. So just some housekeeping notes. Waypoint Talks is hosted as a Zoom webinar. So we encourage you to use the chat box or the Q&A function to connect with speakers and your other attendees. And there will be dedicated time at the end of the presentations for questions and discussion. The recording and slides will also be available post-event on the Waypoint Research Institute website. And we would ask that you complete our post-event survey to share your feedback and help improve future events. We always like to hear what you would like to hear about. There are also attendance certificates for professional development available, and we'll give you some more information at the end on how to access those. So I'd like to introduce today's speakers. I just need to adjust my screen here, so give me just 1 second. Sorry about that. We're having some technical difficulties here this morning. Great. So thank you for your patience. I'm excited to welcome Dr. Nicole Letourneau. She's a professor and the assistant dean in the Faculty of Nursing and Cummings School of Medicine at the University of Calgary, where she holds the Research Excellence Chair in Parent and Child Health. She is a scientific director of the Alliance Against Violence and Adversity, AVA, Health Research Training Platform, and Women's and Girls Health Hub, funded by the Canadian Institutes of Health Research. She is the principal investigator of the Child Health Implementation and Longitudinal Development Child Studies program, examining parenting, genetics, and child mental health and development in the context of maternal depression, family violence, and other stressors. She is the creator of the Attachment and Child Health Parenting Program, ATTACH, now scaling in Canada, Denmark, Brazil, and France, and named a Frontiers of Innovation project by the Harvard Center on Developing Child for its Effectiveness. Sorry. Welcome, Dr. Letourneau. We'll also have Dr. Nazanin Alavi joining us. She is a staff psychiatrist and associate professor at the Department of Psychiatry at Queen's University. With remarkable expertise in the field of digital mental health, Dr. Alavi's research focuses on advancing the understanding and application of innovative technologies in mental health care. One of her significant contributions alongside the OPTT Inc. and her team there involves developing a stepped care model for treating mental health disorders using a machine learning algorithm that effectively identifies the level of care required by individuals. Welcome. And last but certainly not least, we have Kayla Zimmerman joining us. She's the Interim Executive Director of the Patient Client and Family Council, PCFC. Kayla has experience as a mental health worker at a domestic violence women and children's shelter and currently utilizes her background in psychology and her lived experience with mental health and addictions to advocate for patients at Waypoint. And we also have support from Dr. Elnaz Mohimi and Ashley Melvin from Waypoint to facilitate this webinar. So over to you, folks.
I guess, Nicole, you can share your screen if you'd like to. There you go.
Oh, great. Can you see my screen? Yes. Oh, I think I see some nodding heads. Yeah, okay, great. It's hard to see. Wonderful. So it's great to be here this morning. I'm just going to talk to you a little bit about AVA. I think I've got about 15 minutes to do that, so I'll just jump right in. AVA stands for the Alliance Against Violence in University. You heard a little bit about that in the introduction. One of the key things about AVA is that it's a partnership among community healthcare leaders and scholars, and we are working together to address gender-based violence and adverse childhood experiences. So let me tell you more about that. See slides. Right, try it this way. Oh, sorry. Next. Okay. So the Alliance Against Violence on Adversity, or AVA, is a national health research training platform, and we were funded a few years ago now to address this mission, to create the capacity to transform community health and social services to promote the health and wellness of girls, women, and gender diverse people in particular, and those who are at risk or affected by violence and adversity. And the way we've been doing that is through a collaborative, innovative, cross-sectoral, cross-disciplinary, cross-jurisdictional training platform. And the impetus for the mission were two things. First, the UNICEF rankings that continue to show how dismally Canadian children are performing compared to other developed nations. With over the last decade or more now, children's rankings declining relative to the other developed nations, about 37, 38 developed nations. And in the latest survey, found that children were 35th out of 38 nations on mental health, something like 37th on suicidality, and 30th out of 38 on physical health. And we really thought something needs to be done that's different than what has been done in the past to address this issue. And the other issue that we're focusing on is preventing and addressing violence against girls and women. Well, it's been a policy priority across Canada, for many decades, going back to the 90s. We've all seen the increasing rates of domestic violence over the last 5 years. It's really got bad during COVID, but it was the upward tick was already starting more than 10 years ago. And now every 1 to 2 days in Canada, a girl or woman's life is ended due to domestic violence. So again, thinking that we need to do something differently because we've been trying to address these problems as a nation for more than 30 years and it's getting worse. So these are the impetus for the AVA. And our objectives are to strengthen and build capacity to transform community health and social services, use this collaborative and innovative training platform. Our goals are to promote life cycle and intergenerational health, to develop and to do that, we would do that by developing, identifying, delivering, testing, and implementing evidence-based solutions, and have knowledge mobilization be a central feature. And that's even become more central, as you'll hear later, with additional funding that we've received. So in the initial iteration of AVA about 3 years ago, we had around 200, about 150 to 175 partners, and we have grown. We've almost doubled in size in terms of the numbers of academics and community agencies that are working with us. And I think even these numbers are a little out of date. We just keep drawing new members to us as we go forward. And so just a little bit more about the health research training platform. And this is a busy slide, but it's really meant to give you a sense of the 6 core components. And, this circle, which features in a lot of our work, pictures sort of describing AVA, going forward. But we have something called a Triadic Mentorship Program, the Community Agency Internship Program. We have an Early Career Researcher Teaching Release Program. We have AVA Online. We did a lot of work. We're pretty much wrapped this number 5 up, the strategy development, management, and evaluation. Well, at least the work. Now we're writing up what we have done to develop our strategy, and implementation science training, which is ongoing and sort of a core feature of everything that we do. And just to give you another overview, 38,000-foot overview of the Alliance Against Violence and Adversity and our theory of change and how it fits into the national conversations. We took that picture that you can see on the last slide, the circle, and we elaborated on that in the center of this model, and really tried to get a grip on or provide really clear details about all the things that we're doing within AVA, and all this stuff is available on our website if you're interested in taking a deeper dive. But the key points here is that the National Action Plan on Violence Against Women and Gender-Based Violence featured largely in our ambitions here for AVA. And so we really tried to integrate a lot of those pillars into the work that we do. And something called the ACEs and Resilience Research Commons for Communities, which was a national effort, began about 5-6 years ago, and brought a lot of community partners together in the country to talk about how we can address ACEs. That work also was considered greatly in how we developed our strategic plan. But our goals, as you can see at the top here, to transform women's health and social services delivery, build capacity for the next generation of women's health researchers, and in so doing, reduce ACEs, family violence, and gender-based violence. Slide. And so our health research training platform, it offers these things that I've already alluded to a bit, but the Triadic Mentorship, Community Engaged Internships, AVA Online, those are the key components that most people are really aware of. And AVA Online is a huge part of what we do. And I'll talk a lot more about that. But our Triadic Mentorship Program is a new way of educating scholars, essentially, where we connect a graduate student or postdoctoral fellow to an academic leader, scholar in the academic setting, as well as a community leader in the social services sector in Canada, and giving that trainee a different window or lens onto goals or career paths. And also the intention is to give them greater comfort and capacity to work with community agencies and partners once they're finished their education. Something else that we have developed also to provide those same comforts and capacity and competencies is the Community Agency Internship Program, where we go one step beyond the mentorship and actually embed a scholar, a graduate student, or postdoctoral fellow in a community agency to help meet the agency's needs, whether they're to do with evaluation or innovation, to bring their resources to bear on gathering evidence for a new idea that they might test in an agency. And all those things can provide the scholar with experiential learning, and they're very flexible in duration. They last between 3 and 12 months. And it's also connected to the AVA Online program, which I'll speak about in a moment. But this community agency internship program has been very successful to date. We've given over $500,000 to community organizations across Canada for this work, and we anticipate giving around 300,000 more over the course of our grant. And again, this is that circle that I mentioned at the beginning, and the AVA online training modules, that the part I wanted to talk about right now, and that everyone can have access to. The mentorship program and the internship program, they have a smaller, there's a small cohort of 6 to 8 mentees or scholars that we bring in every year, and the competitive program, whereas AVA Online is free and accessible to everyone. And actually, I think it's a real gem in Canada, and I'm really glad to tell you about it. It's you can work toward a training certificate at the or you can pick your own adventure in this program. There's foundations courses, intermediate and advanced level courses, and at each level you get a micro credential, a badge that can be put on your CV. And if you complete all 3 levels of courses, and there's a little capstone project at the end, very, very small, it's a reflection, a few page reflection on your learning, you can get a certificate of completion, which is equivalent to one graduate level course at Athabasca University, and you can get course credit at Athabasca University if you complete these courses. So I mentioned the badges already, and the course that is at Athabasca University is called MAIS 750, just for those interested. And all or portions of AVA Online can be used for professional development or continuing education credit as well in various colleges, for example, social work and nursing colleges, that this kind of programming can definitely contribute to the annual evaluations of continuing competency. And I've even been approached lately about building some things into the foundations courses that organizations could be using in their orientations for new staff. So it's an asynchronous program. It's continuously enrolling people. It's self-paced and flexible. It's English and French. It's free of charge, as I mentioned. And we do co-created content. So academic and community partners are both working to put content up there, and we're always looking for gaps in adding new content all the time. And we put a lot of our AVA webinars that we have weekly on there and that sort of thing. So it's just growing by the minute. How much content is available in there. So it's for community practitioners of all sorts, researchers, everyone, really, anyone who's concerned about ACEs or gender-based violence. And this just gives you a sense of the roadmap for the program. We have 4 pillars essentially, and the ones on the left, the pink pillars here. There's a lot of content about women and gender diverse people and how violence and adversity impacts them or can be managed. The second pillar, that's more in pink, is about girls and gender diverse people and things like the brain story certification and the healing brain, and a lot of course content around how early experiences impact lifespan health. And then we have a big pillar on research readiness and implementation. And a lot of community organizations and scholars alike are loving this because we take deep dives into how to do research that is going to improve services and supports for the girls, women, and gender diverse people. And this content can be generalizable to any kind of area of social or health sciences where you want to improve the implementation of programs and services. And we have some of the world experts providing content in that area. And we also have an important pillar around equity, diversity, inclusion, and accessibility. And you can access AVA online. You just need to become an AVA member. You can click on these QR codes if you're interested right now. And I'm happy to share this slide deck after. You have to create a profile on our learning management system called RISE. And then if you have any challenges at all, you can contact us, but you can set up your RISE profile or pick your own adventure by contacting the AVA email address and just letting us know that you'd like to take part in that part of the AVA online program. We're just about to revamp this whole thing, and we picked a new learning management system that's called Thinkific, and I think it'll be an even better experience going forward, but stay tuned for that. And then just, again, you can see the circle that has sort of been foundational to everything that we've been doing. We began with being a training platform. That's the lower purple puzzle piece. And as we have moved forward, we've attained additional funding to do research and engagement, which I think are the key puzzle pieces actually to moving the needle on girls' and women's health when they're affected by or at risk of violence and adversity in Canada. So just really briefly, we have moved on to find funding to support our knowledge mobilization work. And we have 2 parallel Indigenous women's health streams, one led by Marlon Bennett, who's Canada Research Chair here at University of Calgary, another one led by Malcolm King, who's at the University of Saskatchewan and a former scientific director at the Institute of Indigenous Peoples Health at CIHR. But what we're doing is convening knowledge mobilization meetings, and we're doing that weekly now. We've created an inventory of evidence-based solutions that are in agencies and represent programs and services all across Canada. And we're working to help foster scale up of those programs. And big part of that is actually making this inventory available, and it shortly will be available on our website. And just sort of as I wrap up here, we've also gotten funding now for research projects and persist in this now. This seems to be our latest and most important aim, but we are doing research with community agencies across the nation and focusing that work to improve service and supports in these organizations: Family Service Saskatoon, Fédération des Parents de la Francophonie Manitobaine, and VL Secours. So we're really excited about this work, and we have a few others in Alberta. with CUPS, Kindred, and Suggest, and you can get a sense of the nature of the projects here. But they're all designed to help women and girls at risk in gender-based violence or adverse childhood experiences, and helping just improve the services and supports that are available. So our tagline for AVA and all the work we're doing is working together to make things better. And I'm happy to turn my turn your attention to my other panelists. So thank you for listening. I'll stop sharing my screen now.
Okay, thank you so much, Nicole. That was amazing. And I'd like to introduce our next panelist for her presentation. Dr. Alavi, would you like to start your presentation and do a little brief introduction?
Hey, hello. I I was finally able to, connect. So, yes. Let me find my slides here and share, and I will introduce myself as well. Here we go. Hey, you can see my slides.
Yep.
Okay. So I am Alavi. I'm psychiatrist at Queen's University, and I am a co-program medical director and co-chief of the Department of Psychiatry. So it's a pleasure to collaborate with program at Waypoint, and my relationship with Elnas goes way back, and I am so happy and proud to know Elnas. And we have done a lot of work together, and it continues. And we're building, this work to help and advocate people, and that is how our relationship started. So a couple of years ago, Elnaz reached out to me and said, I am interested to do a work to make a change in students' life and in people's life. And at that time, I thought that she is the person I'm looking for to make a change, and that's how our work started. And she completed her postdoc and started her own work, but our work together never stopped. And that's here we are. We are doing this collaboration together. So a little bit about me. Like at this time, I have a QUOPL, Queen's University Online Psychotherapy Lab, and this is part of my team that you can see in the background. And then OPT is online psychotherapy a tool that it's like a platform or a company that I have built. I'll tell you a little bit more about it. So these are different grants and that we have got, and Elnas is in many of it, and we have done many of it together. So my story goes back to 2007. I thought to share with you. So I am an immigrant. I immigrated from Iran in 2007, and I came to Kingston, and I started a postdoc in clinical psychology. So I'm telling you this story because that is where my work started. I saw many people, and also many women that they immigration is a big stressor by itself, and many people needed help, they needed to see a therapist, but they felt that it was not available in their culture or in the language that they wanted. So I thought, what if I make something that could be available to them like online, and like if the therapist was not with them in the same place, in the same city or even country. And that's when I thought to like develop online psychotherapy, and that's when the work started in 2007. I started making like cognitive behavioral therapy for depression and anxiety at that time, and the work like expanded in years, not only for CBT but for like many different things. And then like we focus on the different things, for example, PTSD, insomnia, OCD, as you can see here. But then I also like kind of specialize in different populations. For example, people who have diagnosis of cancer, people who have diabetes, like correctional officers, like group of students. And like the way like I do that, like, and that is like a lot of work that Elnaz and I have done, is like a qualitative study to have like focus groups. We have like end users, and we will go see like what is the need of like that population specifically. And then we designed the modules. So how like I started my work, it was that I in 2007, I when I designed like a psychotherapy, it was like the CBT is usually like about 12 sessions. So I designed online psychotherapy modules. The patient would receive it through email. So they would receive session one, they would go through the module themselves, and then they would send their homework. They would write back to therapist through email, and they would receive back like the feedback, and the therapist would write back to them. In 2018, with group of like engineers and neuroscientists, I made a platform. I co-founded it into like it is called Opt, as I mentioned. So that is a secured platform, which is secured and scalable, because like email is not a way to do it, and that's how we made Opt. And all these like things are there, and it has like all like different kind of things that is available on the platform, and that's how like we started Opt. And then um, like we expanded that. So I want to like show you how like a session looks like. The things that we added in years also is that the modules are designed in a way that is usually based on story of like one, two people. So like it is that somebody is going, for example, through depression, and the techniques and strategies that they are learning through that module. Okay, like so this is 5-part model, and this is the like the situation that has happened to this person, so they can use this strategy and how to use it. This is a fast pace of like a session, for example, that like module is. So in the beginning of each session, there is a check-in, like how was your previous week, like how was your mood, and then they go through it. Just a second. From the emergency room entrance ramp. Please remove the vehicle from the emergency room entrance ramp. Sorry. So then, like they go through the session, they learn the technique at the end, like it's like share your story, like ask your questions, and then write to your therapist and do the homework, and the therapist writes back to them. So this is how like Opt looks like, and the module and the design. So this is like how I started with online psychotherapy, but like in years we learned like that each person's need is different, right? So some people need online psychotherapy, but that's not enough for every person. People have different needs. Some people need like that their therapist also calls them every week, that they need like weekly check-ins. And some people also need to see a psychiatrist, for example, need medication and like need adjustment of medication. So like we did different studies, and we realized that level of care is different. So we're like there like between like different studies that we did, like group of clinicians in the beginning would we would do like questionnaires, interviews to see what level of care the patients would need. In 2000 and 19, we started adding AI to our work, and the aim of implementation of AI was like different things. So one of that was like to like triage the persons in the beginning to see like what is that like the person need is in the beginning. So the like AI can help us to see what level of care the person needs in the like would need. So is it that like the online CBT is enough or they need more support? The other thing that the AI could help us with is like that, like in mental health, a lot of like measurement that we do traditionally is subjective. Like the person we see, like in like my office, they say, like I say, how are you today? I'm feeling sad, but I don't necessarily know, like in the past month, how they have been. So when the patients do like journaling, like every day, and then like the AI looks into their journaling, they can give me a measurement and a graph like how they have been doing the whole month. So these are the different things that we're looking at in AI. So there are lots of different works at this time that we are working in the combination of the online psychotherapy and the AI that we have been doing. We are working on different algorithms at this time. We have a collaboration with Mayo Clinic and looking at 300 thousand data of patients, making an algorithm that can suggest a medication when the patient is assessed by a physician. So, in terms of the research with the IPV and the future, with all this work that has been done, how we see the collaboration in the future is what services and resources like we can offer like together. Um, like what help with like the online or digital psychotherapy can do. And there is a lot of work that we can do with the like for example the work that we did with the correctional workers and like the patients that had diagnosis of cancer, like the vulnerable population. We got a lot of feedback like that they could like talk about their work and like what they needed in like a place that they felt safe and secured. So like if we can design like a specific like module or like environment that is specifically is designed for their need, that would be very helpful for them. So based on like the like result that we get, that what their need is, what they are hoping for, we can make like the specific psychotherapy modules that would be like helpful for them. So like always, well, like we get like results, but like the question is what you want to do with your result to make a change, to help and to advocate. And this is what some of the things that like I think we could do like together to like improve like the symptoms of like depression, anxiety, and PTSD in this population. So thank you, Ron, for listening.
Thank you so much, Dr. Alavi. What a cool platform. Um, I'm going to pass it over to Kayla from PCFC here at Waypoint. And Kayla, if you could share your screen if you have any slides and do a little introduction, that would be awesome.
Sure thing. Thank you, Ashley. Will do. I'm going to share my screen now. Here we go. And present view. There we go. Can everyone see that okay?
Yep, you're good to go.
Perfect. All right. Well, hello, everyone. Thank you so much for having me. I'm so excited to be a part of this series and to be involved in such an important conversation. I'm Kayla Zimmerman. I'm the Interim Executive Director at PCFC, the Patient, Client, and Family Council. So PCFC is a nonprofit mental health organization that was developed as a consumer survivor initiative. So that means that all staff at PCFC have lived experience with mental health or addictions, either directly or through supporting a loved one. A big part of what we do is rooted in advocacy and using the wisdom of lived experience to create system change. So we have a strong partnership with Waypoint. We have offices located here within Waypoint, and we work very closely with the patients here, both on the regional and provincial sides of the hospital, but we are our own unique organization. So PCFC works closely with the Waypoint Research Institute. This is just a list here of some of the research projects that we're currently involved in, including an intersectional approach to capturing the service needs of perpetrators and survivors of intimate partner violence, led by Dr. Mohimi, Dr. Alavi, and Dr. Hilton, which is the project that I'll be speaking about my involvement in today. So PCFC members collaborate in research in a variety of ways. We utilize the peer-based trusting relationships that we've built with patients in order to bridge the gap between patients and researchers. We take on like an advisory role and advocate for supportive and empowering approaches for patients and participants involved in research. We can be interviewers and co-investigators, and we can provide insights from our own lived experience where that's applicable. So for this IPV study, I'm an interviewer. I interview individuals to learn about their experiences accessing services related to IPV and to learn about where they feel that the gaps are or the areas of improvement are within those services. I'm also able to utilize my lived experience as I have supported a loved one through intimate partner violence. And at my previous job, I was a mental health worker at the Women and Children's Shelter of Barrie, which is a domestic violence shelter. So there's a lot of tools and skills that I learned in that role that I'm able to apply in this project. So last summer, Dr. Elnaz Mohimi asked if I could share some of my insights with the research team on how to make the process of interviewing for this project as safe and supportive as possible. So on August 29th, I hosted a presentation called Compassionate Interviewing, a kind and trauma-informed approach to interviewing survivors and perpetrators of IPV in community and at Waypoint. Excuse me. So in this presentation, I shared various trauma-informed approaches that I've learned over the years. It's worth noting that my presentation focused primarily on interacting with victim survivors of IPV, as that's where mostly my experience lies. Most of the individuals that I've worked with that have engaged in intimate partner violence are people that have been found not criminally responsible due to mental illness, which of course requires a very different approach and a different set of service needs. So this was something that I also addressed in my presentation. So initially, the plans for this study was to interview both patients at Waypoint and members of the community. However, I did feel that there were some challenges to be addressed when it came to recruiting Waypoint patients as participants in this study. Namely being that patients here at Waypoint, of course, are acutely struggling with their mental health, which needs to take priority. Discussing experiences of IPV, whether as a victim survivor or a perpetrator or dual roles, in any case can be quite traumatic and maybe challenging for people that are already in a place where they're struggling. Many of the patients at Waypoint have been found not criminally responsible for acts of violence that they may have engaged in, so it wouldn't be really accurate to address them as perpetrators in the same way that you would with members of the community. And ultimately, this project is really about addressing the service needs of individuals impacted by IPV. But ultimately, the primary service need of patients at Waypoint is their mental health, which they're accessing services for already. So with that being said, it led to a really, really great discussion amongst the team, and everyone was very, very receptive. So ultimately, it was decided to focus more primarily on recruiting community members for this study. So something else I talked about in my presentation was the power and control wheel. So while this resource could use some updating as it was developed in 1984, it's a little while ago now, I still find it a really useful resource because it shows that power and control is at the center of all forms of intimate partner violence. So things like, but not limited to, using isolation, using children, intimidation, using privilege, coercion, are all ways that perpetrators can assert power and control over their partners to keep them in that relationship. So I feel like you really can't have any discussions about IPV without talking about power and control primarily. Um, so I think it's important to note that power imbalances can be inherent in the structure of services that victims and survivors seek for support. So this was something that I noticed a lot when I worked at the Women and Children's Shelter. So for women who were accessing that service and staying at shelter, for instance, they couldn't just come and go as they please. They had to sign in and sign out and let us know what time they were expected to be back. Of course, that's necessary for safety reasons, right? They had to be back at a certain time for like basically a curfew. They needed to consent to having their rooms checked periodically. There are certain items that they weren't allowed to bring in to the shelter with them. So these are just like a few examples, right? And they're all things that, of course, are absolutely necessary, and they exist for positive reasons for keeping people safe. But I think it's important to note that it does create a power imbalance, right, between the women who are accessing that shelter and the staff who are enforcing those rules and regulations. So it's not necessarily something that you can just like change or do away with. Those things exist for a reason, but I think it's really important to acknowledge that and mediate it where you can, and to acknowledge that at times for women accessing that service, it might actually echo the feeling of control that they experienced in their previous relationship. So I think it's something to be very mindful of. So on that note, I think it's important to address power imbalances in the interviewing process. So, is there an inherent power imbalance when you're interviewing someone? I believe there is, or there definitely can be. When you have someone that is asking the questions and then someone that is expected to answer those questions, that's you have someone that's like dictating the conversation and someone that is responding. So that right there kind of shows like a difference in power in that situation. Another way to think about it is like researcher versus subject. So of course we don't want to think about human beings as subjects. That's, not the approach we would take. But I think it just highlights that kind of dynamic. That could be like a power dynamic between the two, between interviewer and participant. And also vulnerability brings into play like a power dynamic. So when participants are speaking about things that are emotional, like experiences with intimate partner violence, that can be really tough to talk about. It can bring up feelings of like shame or fear or anxiety. And that's something that only the participant is feeling. That's not a vulnerability that's shared with the interviewer. So I think that's another way that there is definitely a power imbalance in the interviewing process. One thing I talked about in the presentation was how to shift that perspective, because of course we don't want to go into interviews bringing that kind of energy in, right? So something I try to do when interviewing is shift my perspective that who in the situation has the wisdom and who is seeking that wisdom. So of course, in this case, the person that holds the wisdom and the knowledge and the experience to learn from is the participant, the person that's being interviewed. And it's more of a humbling approach to seek that way and see that I'm learning from their wisdom. So that's kind of a more balanced approach that I just discussed taking for interviews. I also discussed another method for balancing the power dynamic, which is creating opportunities for choice. So why is choice so important? Choice in itself is empowering. Choice means autonomy, influence. It means having control over the outcomes in the situation or the environment that you're in. So something really valuable that I learned from my manager at the Women and Children's Shelter was to create opportunities for choice when interacting with women at the shelter. So for instance, I would often schedule one-to-one like counseling sessions with women just to touch base and assess their needs and develop a wellness plan. So I was really mindful of when I was scheduling those one-to-one meetings with women to create as much choice as possible. So instead of just saying, okay, we're meeting at 1 o'clock on Thursday, we'll use this room. I would say, okay, so at 1 o'clock on Thursday, these are the rooms we have available. So we've got this room that has the really comfy couches, or we've got this room, which is the seats aren't as comfy, but it's a little bit more quiet and a little bit more peaceful over there. Or maybe even it's a beautiful day out today, the sun's shining. Maybe you'd like to sit outside and talk with me in the backyard area. And then that way you can have a smoke if you want to, if that makes you more comfortable. Other examples would be when we'd go into a room, instead of myself just sitting down, I would wait and say, which seat would you like to sit in? And let them dictate where they want to sit in the room. Even small things like, do you like the lighting in here? Like, is it too bright or do you just prefer natural light? What do you like? I can pull the curtains if you prefer that. Or even, do you like to have music on in the background? Does that help you? Like, we can put on the radio if that helps, or if you prefer just quiet, that works too. So those are things that may seem kind of small or insignificant, but they all add up to really giving that autonomy back to the person that you're speaking with. And a little bit goes a long way for sure in creating those opportunities for choices. So with this discussion, at my presentation, I opened it up to a discussion amongst the group, which was fantastic. So I posed the question, how can we create opportunities for choice in a Zoom interview? So of course, all interviews for this project were done via Zoom virtually, which can be quite challenging. It's kind of like limiting, right? So I really wanted to just get a feel for everyone's thoughts and ideas and brainstorming on that. And there were some really great ideas that were generated. One, of course, was cameras on or off. Someone may feel comfortable, like actually talking to a person, may feel more comfortable with that, whereas someone might be like, ooh, that's a little too personal. I don't want to make eye contact. I'd rather just keep cameras off. Providing lots of time options for scheduling, emphasizing the stop, pause, skip. So making sure that participants know that at any time, if they're uncomfortable, they can stop. They can take a pause if they just need a minute, or that if there's any questions that we ask that you're not comfortable with, just skip. Like, you don't have to answer them just because we're asking, right? So those were some examples that were generated. One idea that came up led to a very real change in the interview approach for this project. It was discussed from that group to have participants actually get to choose their interviewers, who they wanted to be interviewed by for this project. So I thought that was a great idea. After that discussion, each interviewer submitted a photo and wrote like a little bio about themselves, so that participants could learn about each interviewer and make an informed choice of who they felt they would be most comfortable speaking with. So I have that here. That shows our little meet our interviewers page, and you can see our friendly photos and little explanations about little bios, who we are, what we do, a little bit about us. So I think that is something that I'm so glad that was generated from that discussion, because I think it went a long way for creating more comfort and more choice for participants in this study. I think it's just a really great example of how a project can grow and change through collaboration. So, yeah, I'm so grateful to be able to contribute my perspective to this project and work with a team that is so inclusive and collaborative. I think it's a great testament to how much a project can change through partnership and sharing unique perspectives. Thank you all so much for listening to me. I've added my contact information here if anyone wants to reach out with any questions or anything. And also, I'm happy to answer questions at the end of the presentation. Thank you all very much.
Thank you so much, Kayla. What a inclusive and adaptable way to kind of alter interview processes to make people a lot more comfortable. And as someone who participated in the training, I find that I still use the skills even today. So amazing. Thank you. And I'd like to, yeah, no worries. And I'd like to thank the rest of our speakers today. Before we transition to attendee questions, I'd like to ask each of our speakers a few questions. So for Dr. Nicole Letourneau, you've worked across the country and globally on projects related to intimate partner and family violence. My question for you is, how do you think involving different communities could change the way we do research moving forward?
Well, it's a great question. And for me, it's really the only way to do research is with community. I mean, if you think of it, there are a couple ways we could do research on intimate partner violence and adverse childhood experiences, gender-based violence. We could be just, in our universities, putting up a poster in a grocery store, or, advertising for people to join our study. Could you, we've got a program we want to test. Are you, inviting people to take part and then checking the inclusion criteria and then doing a study and determining the impacts of some intervention or other and and then publishing it. That's sort of like the traditional model, I would say. But what's much more valuable, I think, is working with community organizations where you can help them develop, test, implement, improve services to support their clients through research. You can do the very same project, but you're doing it in a way that builds capacity, that can leave a legacy of an intervention or program improvement in an agency and has value added for the agency, for their clients, and so on. And it's just much more realistic and real world. And as we all know, I mean, studies that people do in more controlled settings, sometimes the biggest challenge is converting them over into the real world. Well, if we just start with the real world and just deal with it, we're more likely to manage and work through all the issues that might arise that can undermine effectiveness of services, programs, supports, that kind of thing that we're testing. So for me, it's just the obvious way to do work. However, it's a challenging thing for lots of people. And, I can see why, because it takes a lot of time. It takes a lot of relationship building, a lot of relationship nurturing and trust, really, organizations that we work with very vulnerable groups. And they really need to trust that your team is going to come in and work with the agency staff and with their clients in a way that's respectful and all of that. So I hope that answers your question, but I think it's the best way to do research, and that's why AVA exists, really, is to kind of support that ability to do this kind of work. And I think that Canada is ahead of the game. You asked what globally. I think that Canada is ahead of the game in supporting communities do this kind of work. Maybe it's because of our universal healthcare system. Maybe it's because we have been encouraged to work cross-sectorally by the government in various funding opportunities. But we have some amazing expertise here in implementation science in Canada that has been brought to bear in some of the other work I've been doing globally. And when I think of who I am listening to and who I'm reading, Ian Graham being one key person who's part of AVA, and there's a lot of others, but Canada really punches above its weight in terms of implementation science. Implementation science is done with community. So I think that Canada is also exporting some great expertise that brings this approach to bear in other nations. So there you go. That's my answer to that question.
Awesome. Thank you so much. And to Kayla, you've led a workshop on how to explore people's experiences in a more compassionate and respectful way. What impact do you think that this has had on how the research team connected with participants in the IPV service study?
That's a really great question. I think the big thing is taking the time to look into the things that maybe we take for granted, or the things that go unnoticed, right? Like those subtle power imbalances that maybe you wouldn't take into consideration otherwise. I don't know. I would say I've gotten some really great feedback from people that attended that little presentation, and just even having little small tips and tricks for how to navigate. I think especially when you're talking about things that can be really sensitive and really difficult, having the confidence to do that. Because I know a lot of the time it can be very easy to get focused on what if I say the wrong thing, or what if I do the wrong thing, or and it can be a little bit anxiety inducing. So I think just having even just small tips and tricks just to approach it in a more comfortable way, and just to make sure that you're always thinking about that person's perspective and what brought them here into that conversation, I think makes a difference.
Awesome. Thank you. And for Dr. Alavi, you've helped create an online mental health tool for a multitude of different populations. What kinds of online support do you think could make the biggest difference for intimate partner violence survivors and other people affected by domestic violence?
Thank you for like the great question. So I think first of all I think online psychoeducation programs are very important. So you know, if like they could have access to psychoeducation, that's where we should start because that is like missing a lot. So if they could have access to that. The other thing is like the different online psychotherapy, right? And there are different kind of psychotherapy, and that is like I think what is missing because I think the psychotherapy is what is like is evidence-based, and for like each kind of like you know when like this kind of violence happens, like it could cause like different kind of disorders, right? It can cause PTSD, as we know, it can cause depression, can cause anxiety, and each of that like the kind of treatment is different. When first of all, like that is available online, like they can have access to each of them like separately based on their need. And also, like one of the things, especially for this group, it could be helpful that if it's online, they can have access to it anytime and anywhere, right? So, which is very helpful. And like in terms of confidentiality, right? Like also sometimes being anonymous, like it could be very helpful. And they can like openly write about what they want to write. And it's not even only writing, they can talk about it, right? Because like it is like speeches available, they can write, they can say what they want. So like having like psychoeducation like modules, having like, you know, psychotherapy available online so that like it can be accessible like anywhere and anytime when they need it, and also like I think because like we have like we see like the violence especially like you know in like immigrants, like if it could be available in different languages, right? That is very important, I think. So like that is like the next level I think we should take which is very important. So there is a lot of work that I think it should be done, and so I know like there is also accessibility like that has like there is a lot of research that like does everybody have access to internet or like you know like a cell phone or stuff, but most of research has shown that most people have anyway like can find like access to the internet. There are like libraries, for example, or most people have a cell phone to use it, so it's not that difficult. So that would be my answer, that like so we can have like find like or make more resources in like understanding like the whole thing, and who they can go to find somebody to teach them where to go next, what to do, how to help themselves.
Amazing. Thank you so much. And this question is for all of the panelists, so feel free to jump in. But if there was one big lesson from community partnerships that you think more people, like healthcare workers, researchers, or even families, should know about responding to intimate partner violence, what would it be?
Your question, sorry, Nicole. So your question, yeah.
Yeah.
No, I think it kind of goes back to what I was saying, where we need to work together more. I think that there's a lot of untapped resources in Canada. And if and that's what the whole purpose of AVA really is, to bring together the academic expertise with the community agencies that are really working so hard to address the needs of their, you know, these high risk populations. And I think by working together, we can do so much more to help improve population health in Canada. And the message would be, I guess, to funders, both for social services, service delivery, and for researchers working in with these at-risk populations, and that the funding that we receive, I'm in that camp of so to speak, for the academics, but all the incentives should be for us to work together. And I don't think they do. I think they do sometimes, but I think that the more we are apart, the worse it is for Canadians. So that would be the message. I guess maybe it's to everybody. Anybody who has any say over where money goes should be putting the incentives in place for academics to work more closely with community agencies that desperately need the support to make sure that the services and supports that are offered to their clients are the best they can be, evidence-based. And I guess we're aligned with that is a message that we should not give up on science. There's a big anti-science movement, and I've even heard people say, well, you shouldn't put money toward that research when you can just put it toward service. Well, for me, they're intertwined, and I don't see why you would pull them apart, because even any service delivery person would know should evaluate what they do, which is science. Just so I think we need to, go against some of these trends globally and make sure that Canada stays a leader in how we support our services that are outside actually of the traditional healthcare setting and in the community, to make sure that all the resources are brought to bear to improve the health outcomes for populations in Canada.
Thank you so much. And Kayla, I see that you've unmuted yourself.
Sure. Yeah, I was just thinking more about your question. I don't know if I have any one direct answer necessarily, but it's just, I think when I think about the services that are like available, there's so many gaps and inequities, right? And I think a big part of that is that we have like different siloed resources functioning kind of independently and separate from one another. And I really just think that the only way to address that and change that is to create like almost like a net of community partnerships, right? And to be able to address all of those gaps. And I think also it takes a real commitment to do that, because it's not always maybe the most convenient or easy way to go about things, because a lot of the time it can mean having to make changes or having to do something that's more time consuming or but I think being committed to that and being flexible to make those changes as they come up through collaboration with other organizations, other groups, other individuals, like I've seen with this project, I think that makes all the difference.
Amazing. Thank you. And Dr. Alavi.
Yeah. So I totally agree as well. So one of the things I wanted to say is that, feel that all different teams and groups that are trying to advocate and help are doing like their work like towards the same goal, but like as you both mentioned, like the main thing is to work together to towards the same goal. One of the things like thinking about your question, that I think we have to be cautious about that, if like one message I want to say, like based on experience in clinical work, is that sometimes we do our work not thinking about the next step, what is happening, right? To hand it over to the next team, right? Because this population is very vulnerable, right? So I think that I'm doing my work, trying to help and advocate, but I am not communicating well with the next team who is taking over. And if we don't work together very closely, because I think the situation is not very they are very high risk, as you mentioned, right? So if we not work if we don't work very closely, we are putting the person in a higher risk situation. So I think that we should not only think about the okay, I am trying to advocate here, but I am just thinking about this moment. And that is what the message I like to give to the families and the population, that when I'm sitting in my office today, my role is to do this because that is my role as a physician. No, I think I have to see the bigger picture. So if I don't communicate with you who is the team in the community, I'm putting the person in a higher risk. So I think like working together is very important, and like we have to like follow up, right? Otherwise, we are not helping the person. And I think this is like in many places, like, or like in some, it's missed. And although like we're all trying to help and like doing research and advocate, and this was like I have to tell you, like it was one of like the first places I really like, you are a great group and you are doing something big, and I was like so happy and proud to be part of this because you were really like doing it, and it is so great to work with you.
Thank you so much. And we do have a few minutes left, so I'd like to turn our attention to any questions that our attendees may have. And I see that Nicole has answered one in the chat. But if there are any other questions, please take a chance and type them in the question and answer box or in the other chat box. And we'd be happy to answer those. So we'll give everyone a few minutes to see if they have any questions.
I guess I could just put a verbal plug into Robin to reach out to me because we would be really interested in that kind of content, Robin, if I understand your question. I don't think we have anything about that on Leva Online as yet, and that's exactly how we roll. So we find out a gap and want to try and fill it. So please do reach out to me. Yeah, great. Thanks, Robin.
All right, so it looks like we don't have any other questions. If you do think of a question after this session, you can feel free to email us. And I'll hand it off to Christy now to do the closing.
Awesome. Thank you. Thanks everyone for joining us this morning, and thank you so much to all of our wonderful speakers. So just a quick reminder, post-event, and we will be sending out that post-event survey, so please keep your eyes out for that. If you would like an attendance certificate for professional development, you can send me an email. My email is there on the screen, and I would be happy to help you out with that. Thanks again for joining us, and next week we have our last talk in this April series where we will be discussing the future of IPV research. It'll be an interactive discussion on gaps and next steps. So we hope to see you there. Thanks for joining us this morning, and have a great rest of your day.
Great. Thanks.
Thanks so much, everyone.
Bye.
Bye.